remove one of these, right?
We are now live on YouTube. Welcome everyone to expert discussion at Shankara Cancer Hospitals. As part of Brain Tumour Awareness Month, we have our experts from Shankara Cancer Hospitals, Bangalore and Shankara Cancer Hospitals, Bhubaneswar, to discuss about brain tumors and its treatment. I now hand over the discussion to our experts.
Good evening, everyone. We welcome you all to this live discussion on brain tumor and its awareness. I would like to begin by asking the panelists to introduce themselves. So I'm Dr. Karthik Rishi. I'm a senior consultant radiation oncologist at Sri Shankara Cancer Hospital, Bangalore. My specialty is to treat brain cancer with radiation. Dr. Arun? Okay, we can ask Dr. Sandeep. Can you introduce yourself?
Hello. Good evening, everybody. I'm Dr. Arun. I am a neurosurgeon. His audio is muted, I think, Sandeep.
Hello, Dr. Sandeep. Can you introduce yourself? I think we can't hear Dr. Sandeep. So Dr. Vijay, can you introduce yourself?
Hi, good evening. I'm Dr. Vijay Simha. I am a consultant medical oncologist at Sri Shankara Cancer Hospital in Bangalore, and looking forward to the discussion on brain tumors and this brain tumor awareness.
We also have Dr. Satyajit, who's joining us from Bhubaneswar. Dr. Satyajit, can you introduce yourself?
Yeah, hi everyone. I am Dr. Satyajit Rath. I am consultant radiation oncologist, Bhubaneswar, Bakshi Shankar Cancer Hospitals. It's nice to join this discussion. Dr. Karthik, over to you.
Dr. Arun?
Yes, sir.
Can you introduce yourself? We were not able to hear you.
Yes, sir. I am Dr. Arun. I'm a consultant neurosurgeon. I specialize in all complex neurosurgeries, including metastatic workup and metastatic surgeries for brain and spine.
Yeah, Dr. Sandeep, would you like to introduce yourself?
Yeah. Hi, everyone. Good evening. Myself, Dr. Sandeep Desai, and I'm a consultant radiologist at Bangalore Center. And I'm a radiologist. I deal with diagnosis and early recurrent involvement to diagnose early recurrence as well. This is my role.
Thank you, everyone. I'll just like to begin the discussion by telling the viewers that as oncologists, we see quite a lot of patients who are unfortunately who have been diagnosed with having a brain tumor. A brain tumor not only affects adults, but a significant proportion of children also are affected with brain tumors. So how common is it? It is what we say is in terms of a lakh. So if there are 1 lakh people, roughly around 5 of them can be affected by brain tumors. And because the brain is such an integral part of our body, even a small tumor there can have large ramifications on a lot of functions in the body. So which is why it is very important to diagnose it correctly and also provide the right treatment. So let us begin by asking a few basic questions. So Dr. Arun, as a neurosurgeon, most of the patients who are recently diagnosed would be coming to you for the initial management. So how do you commonly see these patients presenting as?
Yes, sir. So usually these patients present to us with the commonest is the recent onset of headache. or the family members might have noticed that he is having a recent onset of forgetfulness, some confusion, disorientation, or a seizure episode might have got them to look into what is happening. Or sometimes they might come out in the later manifestations like weakness and complete paralysis. The headache
How
is
often?
usually associated with some sort of vomiting and nausea, and they usually say that the headache is relieved by vomiting. This tells us that the headache is a raised ICP headache, raised intracranial pressure headache, usually presents with some blurring of vision or headache that is relieved by vomiting.
So how often do they present to you as an acute emergency situation?
Emergency, very less common because the tumor usually takes some time to grow and show its manifestations. However, very late into the presentation, if they have had an acute bleed inside the tumor, they can come with sudden loss of consciousness in a comatose state, where we need to take up the surgery as an emergency and decompress the tumor as much as possible.
So as I was saying, even children get brain tumors. So how will a child present with a brain tumor? It is not going to say that the child cannot say that it has a headache or express its difficulty. So how will the parents be able to identify it, or how is it presented?
So usually in children,
I think your audio is not clear.
it will be some sort of difficulty. Yeah. So the importance of that being picked up either by the parents or by the teachers in their class is very important, where they will be sometimes having visual issues, where a child who's been sitting in a third or fourth bench usually can't see, and they complain that I'm not able to see, and they are asked to sit in the front. So that should be something that they should look into and not just say that they're not concentrating. Or if they can also present with something called as silent seizures, where they'll be seen as wandering off. Usually, the some behavioral change or wandering off is seen by parents as child is not showing interest in studies or something like that. So that also needs to be intently seen into and probably investigated further.
Right. So just to tell the viewers that not all tumors in the brain are considered as a cancerous or malignant tumor. So we can have some tumors which are considered as benign. Benign means they are very slow growing tumors, but because the brain is like a closed cavity, even a small benign tumor can cause compression on the nerves, or it can cause pressure symptoms. And at the other end, you have very aggressive or malignant tumors which need to be treated more aggressively. So in general, to make a diagnosis of a brain tumor, we need to do some sort of scan or imaging. And the most common imaging for and preferred imaging for brain tumors is an MRI. So Dr. Sandeep, can you throw more light on what are the imaging modalities available to diagnose a brain tumor? We can't hear you. Can you unmute yourself?
Am I audible now?
Yeah.
Yeah. Initially, the first investigation of choice is a CT scan, which helps us to localize the lesion, as it is much easier and faster. So once we can make out whether the lesion is in the supratentorium or the infratentorium, or there are certain characteristics like blood or calcium, which is better made out on a CT scan, following which the patient undergoes a MRI for further characterization. So MRI is a study where there is no radiation involved, and which helps us to characterize the lesion better. Not only the diagnosis, this recent advancements in technology also help us to grade the tumor, whether it is a low grade tumor or a high grade tumor. These are possible with the advent of technology like spectroscopy, diffusion imaging, we utilize all these sequences to come to a logical conclusion of what is the diagnosis, what is the grade of the tumor, and how urgent is it. We can convey it to the neurosurgeon based on the presence of midline shift, presence of large bleed associated with the tumor. It's possible with the MRI. And not only that, apart from after treatment also, MRI helps in recurrent diseases as well.
So what you're saying is you would prefer to do an MRI over a CT scan for brain
Yeah,
tumors.
exactly. We prefer MRI for better characterization of the lesion. But MRI takes a little longer time, and the physician generally first performs a CT scan, following which a MRI is done.
So what about a PET scan, Dr. Sandeep? Now, whenever we talk about cancer, the common perception is that a PET scan will give a very good idea about the lesion and it will scan the entire body. What do you think is the role of PET scan in brain tumors?
See, when a scan is performed, if it is a solitary lesion, like I meant to say, it is a one lesion and it is an elderly individual. So we are thinking in terms of this is a lesion arising per se from the brain parenchyma. So in such a case, MRI would be beneficial. But if we see multiple lesions, so as we come across, there are two compartments like the supra and infratentorium. So if there are numerous lesions and predominantly the lesions are in the infratentorium, it we draw conclusions that this is not primarily from the brain or it can be a metastatic lesion, and the most common namely the lung or the breasts. In such a case, we prefer to do a PET CT so that we can identify the primary, and this could be metastatic. Numerous lesions, preferably to go ahead with a PET CT to identify the primary.
Okay. So Dr. Satyajit, what are the common brain tumors that you encounter in your day-to-day practice?
Yeah, so speaking of brain tumors, being a radiation oncologist, where I deal with the radiation part, one of the most common tumors we deal with in adults are astrocytomas or gliomas. So gliomas, astrocytoma and gliomas are tumors which are divided into 4 grades. So as we go to grade 3 and grade 4, these are called higher gliomas, like glioblastoma, GBM is grade 4 tumor. So this grade 3 and grade 4 tumors are one of the most common tumors we see in practice, and these tumors also carry a bad prognosis. There are some tumors like benign tumors which we commonly see in the brain, which are like uh, benign tumors belonging to the pituitary area or the craniopharyngioma, which is another tumor of that area. So this is a tumor which arises just above the base of the skull and in between the base of the skull and the brain, just for the understanding of the general public. And then in pediatric age group or childhood tumors, we see tumors like astrocytomas and medulloblastomas very commonly. So medulloblastoma is a tumor which is different from other tumors in terms that the radiotherapy fields are much larger than compared to standard fields where we only treat brains. Maybe we'll come to that later. And then again, one type of tumor we treat is metastatic brain tumors. Like Dr. Sandeep mentioned, there are metastatic tumors from breast. There can.
Yeah, I think we can direct that question to Dr. Vijay. So, Dr.
Yeah.
Vijay, which cancers commonly spread to the brain, and how do you identify whether the cancer has spread to the brain?
Yeah, so like Dr. Sandeep sir mentioned, the more likely it is if we see the general population that the brain tumor is secondary to some other cancer in the body rather than it being a primary. This is especially if there is, for example, if there is a male who is a chronic smoker and he has multiple tumors seen in the MRI, or if it is a lady who has previously treated for breast cancer or has a breast lump along with some symptoms of related to the brain like headache or vomiting and seizures. So it is most likely a spread from the breast. So in males, the most common cause of a spread from a to the brain is from the lungs, and in the females, it is most commonly from the breast cancer. There are some other cancers like kidney cancers and some skin tumor called melanoma can also spread to the brain. Thyroid cancers can also spread to the brain. Literally, any cancer in its advanced stages can actually spread to the brain. But if we see in general, the most common cancers that should be remembered in a person whom we think that who has a brain tumor spread from some other site is lung cancer, breast cancer, kidney cancer, melanoma, and probably thyroid cancer.
Okay. So one of the first treatment for brain tumors is surgery. So Dr. Arun, what are the different surgeries that are available for a brain tumor, and how challenging is it to do a brain tumor surgery?
Yes. So once we have a radiological diagnosis and a clinical diagnosis and for the surgery, so in case of a primary tumor, that is a small tumor or low grade tumor, the option will usually to be to do a safe, wherein we'll try to remove as much usually done in younger individuals who do not have any deficits already when they are presenting, so as to preserve the maximum function and also remove the maximum tumor that is that we can give for biopsy. However, in patients who already have a deficit, or when they have a large tumor, or if it's a tumor that is beyond our surgical listing where we can't safely resect most of it, we can go for a decompression, which is the most important thing, because we need to give the brain some space to expand. And then following that, once we get the biopsy report, we can go in for chemotherapy, radiation, and other options that we have to reduce the size further.
So is it possible that
So
some of the tumors
once we get
cannot
to
be
know
accessible for surgery?
the tumors like brainstem gliomas and deeply situated tumors in the basal ganglia, well, when we try to remove it as a whole or when we try to resect most of it, it usually give rise to a morbid deficit. So in such patients, when we know that it may be causing more deficits, we can either go for something called as a stereotactic biopsy or a navigation guided biopsy, where it will be done only through a small keyhole, where we are assisted by the robotic system that will give us the XYZ coordinates. So we can take out just a small biopsy, send it for something called as a frozen section, get to know that we are in the tumor, get it over to the chemotherapy.
So I think it's an important point that we need to know that in brain tumor surgery, it is not always possible to remove the entire tumor completely. This is because we need to make sure that the normal nerves and in the brain are also protected and are not harmed by the surgery itself. So what the surgeon will do is they will remove as much as possible, and the remaining need to be treated with other modalities such as radiation or chemotherapy. So, Dr. Arun, there have been a lot of advancements in the field of neurosurgery. We know now that a patient can even be awake while the surgery is on. Can you throw some light on that?
Yes, sir. So, in cases where the tumor is involving the more eloquent areas of the brain, such as the speech area, memory area, or the motor area, where patient, even if we go, so in these patients, we have an option where the patient is completely awake, he is anesthetized, local anesthesia is given, and some sort of sedation is given. So when we go on
Hello.
the brain, we will check to know whether that is causing any deficits while speaking or playing music, as you would have seen. We know that it is safe, we will go for an excision of that part. Once some deficit occurs, immediately we stop at that area, go to another area where it is safe and try to resect from that area. So in this way, we can prevent the deficits that happen to the patient while also being able to resect the tumor that is required.
So Dr. Sandeep, similarly in MRI also there are a lot of advancements. Now MRIs are placed within the operation theater. So how does that help the surgeon in his surgery?
There are various sequences which aid the surgeon. For example, diffusion sequences. By performing that sequence, we will get to know, is it a post-operative change or a residual lesion? So that comes in very handy, which helps the surgeon to take out the tumor. Not only that, while doing a biopsy also, just as Dr. Arun spoke, the centrally located deep gray lesions. So sometimes the area of restricted diffusion is the area which has to be targeted, which helps us to grade the tumor better. So not only that, we have perfusion studies also where we administer contrast, and there are certain parameters we derive, something called as a RCBV. So higher the RCBV, higher the grade of the tumor. So those areas have to be addressed while doing a biopsy, and these diffusion weighted sequences come in very handy.
Okay. So what are the
Sir,
challenges?
if I may add,
Yeah. Yeah, please do. Yeah.
if I may add, sir. Yeah.
Yeah.
So we also have things like tractography and such. So wherein we can actually get a 3D, location of the tumor and how it is affecting particular tracts inside the brain. So when we have this and then coupled with our navigation system, we can avoid that particular tract or know how deeply we can go without affecting a particular tract, and hence we can come out without giving any deficits. So basically in our surgery, the most important thing is to resect the amount of tumor that we can without giving any deficits to the patient, without causing any weakness or permanent damage.
Dr. Sandeep, we were talking about children. So how safe is it for children to undergo scans? And how get them to cooperate during an MRI scan, which may take like 30-40 minutes?
So basically, MRI, there is no radiation involved. So the patient can undergo MRI as many number of times as possible. Unlike a CT study where there is some radiation involved, and we try to avoid in children especially. MRI, we generally request the anesthetists and fix up an appointment with the anesthetists, and we sedate the patient for that period of time before MRI is performed. So kids above 12 to 13 years can comprehend and cooperate, but younger the child, we need the help of an anesthetist to proceed with the procedure.
So Dr. Arun, what are the challenges in operating in a child? And one of the common questions that parents would ask is, will it affect the growth of the child subsequently? So how do you explain to them and convince them for surgery?
So in children, the first and foremost thing is about the anesthesia and its effects, as well as the blood loss during the surgery. So we may take utmost care not to cause any blood loss, standby of blood products required during surgery. About the tumor itself, the resection of the tumor may cause some issues in the immediate postoperative period. However, children have the brain has a great deal of plasticity, what we call, where the other parts of the brain learn the actions of that particular part. So the end deficit in a long-term follow-up will not be there.
Right. So, Dr. Satyajit, once surgery has been done, when do you suggest or advise radiation for brain tumors?
So, as Dr. Arun said, when the patient gets operated at their end, and then the patient comes to us at second or third week post radiotherapy to us, post surgery to us. So we evaluate the patient and to see that if all the sutures are healed, how it is the present condition of the patient, can we consider the patient for radiotherapy? And after taking considerations into all these factors, we generally decide that the patient should be treated between the treatment should ideally start at 4 weeks, but sometimes there may be some morbidity which can delay to 5 and 6 weeks, which is okay. But we prefer to start at 4 weeks. And before starting, we need the pre-surgery scan, and also we need a scan of the current standing of the disease. So we generally prefer to take scan after 3 weeks of the surgery. So the residual edema and the inflammation has subsided, and it allows us to clearly see us if there is any tumor left, or is it completely clear. So we take an MRI around 3 to 4 weeks, and we prefer to start at 4 weeks if everything is fine and sutures are healed and patient is general condition is okay.
So, what can you tell to the audience what exactly is radiation? Because the word radiation instills fear in the common man.
Yeah. The word people are generally afraid of radiation, that it is a very toxic treatment. It will completely char their skin. I like to tell the audience that it is not like that. The treatment has evolved in the last 2-3 decades. From the time even we are studying to 10 years from now, it has evolved a lot. So radiotherapy is basically a high energy X-ray or high energy gamma rays which we use to treat, and this comes from either from a source which is there in the machine, or it is generated by electricity. So the techniques have evolved from say 15-20 years down the line to now. We have very advanced treatments. How do we deliver it? We take a CT scan of the patient. On the CT scan, we plan the things where we actually paint the volume. We call it dose painting. So suppose a patient has a tumor near a right ear. So we mark that area in the CT scan slice by slice. And then we give our medical physicists to plan it. They plan it and we deliver it. How is it delivered? It is delivered generally from Monday to Friday. So Monday, Tuesday, Wednesday, Thursday, Friday, we give radiations. Then Saturday and Sunday, it is off. So one thing is, how frequently? 5 times a week from Monday to Friday. How many weeks? So it varies from tumor to tumor. For a grade 3 or grade 4 glioma or astrocytoma, we generally treat with 6 weeks. So 1 week is 5 fractions. We call it fractions. And 6 weeks is 5 into 6, 30 fractions. So generally a glioblastoma or a glioma will require 30 sittings of radiation. We call it 30 fractions in our language when we talk with our colleagues. So 30 sittings is what we do. So what we do is as I said, patient comes and lies on a CT scan. We take a scan. We use a thing called mask, which we use to immobilize the patient. Why do we need to immobilize the patient? Because if we immobilize the patient, the head of the patient will not move. So we can deliver it to the accuracy of 1 to 2 mm. So currently we have systems in place where we can deliver the radiation to the patient with an error of less than 1 to 2 mm. What it does is that it reduces the side effects beyond the area where we need to treat. So patient has maximum effect and minimal side effect. So Dr. Karthik, should I talk about the newer techniques also?
We'll come to that.
Okay.
So before that, I would like to ask Vijay, what are the challenges in administering chemotherapy for brain tumors? What are the common drugs that you use in treating brain tumors?
So the most important challenge in treating brain tumors with simple medicines is that whatever medicine that we administer through the mouth or into the vein really actually does not penetrate and reach to adequate concentration within the brain. This holds for most of the drugs that we use for treating most of the cancers like breast or lung cancer. The most of the drugs cannot reach in adequate concentration into the brain. This is due to the presence of an anatomical barrier called as the blood-brain barrier, This is sort of a nature's protective mechanism so that the brain is protected from several toxins that can be potentially ingested by humans as well as in animals. So there is a blood-brain barrier that is present in all of us, and this barrier is a significant impediment in preventing drugs from reaching the brain in adequate concentration. That's why in the treatment of brain tumors, always use of medicines alone is often not enough. This is the rule almost always, except for some tumors like lymphomas, where probably we may be able to treat. But for most tumors, we will not be able to just treat with medicines. Having said that, some of the medicines have been shown to reach adequate concentrations into the brain. And the most commonly used medicine that is used for brain tumors per se is a drug called temozolomide. So this is used in the treatment of high-grade gliomas. This drug has been used both along with the radiation to be given as a radiosensitizer. That is, the drug increases the efficacy of the radiation by sensitizing the tumor to the effect of radiation. And also, after the completion of radiation, it is given as a standalone pill. So, radiation, when we deliver to a tumor region, it helps in some ways because it partially destroys the blood-brain barrier around the tumor, at least in that region. So it helps in increasing the penetration of the drugs that we give for the treatment of this tumor. So when we give the tablets, temozolomide tablets, we usually give it along with radiation and also after radiation. In some of the pediatric tumors which are fast growing, there are
sorry, just to interrupt you. So patients commonly ask, why are both given together? They are more scared that if you take both chemotherapy and radiation together, side effects can be more. What is the reason for combining radiation and chemotherapy?
Yes, as I told you, the chemotherapy has a lesser role. Radiation has the primary role. The main role is being played by the radiation in the treatment of brain tumors. The chemotherapy is just being used as a fuel to add to the fire. So just there is a big fire that is going on, and just add a little bit more of ghee into the fire so that the fire burns more brightly. So that is the role of chemotherapy. But again, we need not be afraid that this will cause more side effects, because the dose of the drug that is given along with radiation is almost 1/4 or 1/5 of the usual dose that we use to treat it as a standalone medicine. So this is actually a radiosensitization. It does not actually lead to significant increase in side effects. This has been proven in clinical trials that there is not much increase in side effects or morbidity by combining both these chemotherapy tablets as well as radiation.
Dr. Karthik, if I may add something.
Yeah.
Yeah, so for the audience, we have a lot of patients do ask, as I told, that after CT scan, just before starting radiotherapy for a brain tumor, we generally do a MRI. So in the MRI, if there is no tumor, the patients generally ask, doctor, if the neurosurgeon has completely taken out the tumor, why are you giving radiotherapy at all? Disease is not there. So the answer is the neurosurgeon has taken out the tumor, gross tumor. We sometimes there is a very good surgery and we don't see any tumor in the post-surgery MRI. But the role of radiation here is that there may be some submicroscopic or subclinical disease which might be present. And one thing in higher grade brain tumors is that in the tumor, surrounding the tumor, we have some region called edema, which is a fluid accumulation around the tumor. There might be tumor cells present in there. So we need to address those submicroscopic and subclinical disease. That is why radiation is necessary.
Yeah.
One more thing I would like to add here is that when we start radiation after surgery, and let us say after surgery that the patient has, say, weakness of the hands or limbs, often it is a misconception by patients that by giving radiation and chemotherapy, that actually the power in the uh, weak limbs that have been after the surgery is likely to recover. But it is, we have to emphasize that the purpose of giving radiation and chemotherapy is actually to prevent future recurrences. And recovery of power in the limbs is mainly, if ever, like Dr. Satyajit said, that resolution of the edema that may help partially in recovery of the power, and also aggressive physiotherapy, which must be done during and even after the completion of treatment. So these are the things that will actually restore the power. And it is very important to emphasize to the patients that giving radiation and chemotherapy to a patient who has already a decreased power in any of the limbs after surgery will not restore the power. We are not giving the treatment to restore the power.
Yes.
Yeah, Dr. Satyajit, there are different techniques of radiation available. There are techniques like 3D CRT, IMRT, etc. Can you just list the techniques and the major differences between them briefly?
Yeah. So previously when we used to be students, we used to treat with a machine called Cobalt. So that was a very primitive machine that is still available in some places in India. So with that, what used to happen that although treatment effect used to come, but side effect used to be very large. The slowly improvement happened, and we got a method called three-dimensional conformal radiotherapy, 3D CRT. So what it does that it reduces the treatment volumes. So imagine a square and a circle inside the square. We want to treat only the circle inside the square, not the whole square. So we use newer techniques like 3D CRT. And then one evolvement of that technique is IMRT and VMAT, which are newer modalities. So with those techniques, what we do is we accurately deliver doses to the targeted area only. Beyond 3 to 4 mm of that target volume which you want to deliver, like suppose the tumor is very near the eye. So it is 5 mm to 1 centimeter away from the eye. So we want to spare the eye completely so that the patient can see normally even after the radiotherapy. So with these techniques like IMRT, IGRT, and VMAT, these are the newer techniques. We can completely spare vision. We can completely spare any organs which you want to. Suppose a tumor is in areas called brainstem, which is very vital to our functioning of heart, our respiratory functions, and many vital functions we undertake. So we have modalities where we can spare these tumors. There are some benign tumors like pituitary adenomas, like vestibular schwannomas. These are tumors which appear near the base of the skull, craniopharyngioma, and also some of the brain metastasis. Dr. Vijay and Dr. Sandeep earlier talked about. So if there are small tumors which are near to very critical structures, we have evolved some techniques which are called SRS and SRT. So that is called sutureless surgery, that is stereotactic radiosurgery. So what we do is we deliver a very high amount of dose to a very limited volume in a very less number of fractions, which can be one in case of SRS, stereotactic radiosurgery, or stereotactic radiotherapy, in which we deliver in 3 to 10 fractions. We have newer machines in which, suppose a brain in the previous 10 years back, a pituitary tumor was treated with a 5.5 to 6 weeks treatment of 25 to 30 settings. Now we have evolved techniques in which we can give radiotherapy to a pituitary tumor in one sitting with almost equal effect and very negligible higher side effect. So these techniques like SRS and SRT have allowed us to treat tumors like pituitary adenoma, vestibular schwannoma, and also brain tumors of at least maximum 3 to 5 in number. Suppose a patient with lung cancer is doing very well otherwise and has developed 2-3 lung mets, which are small in size, say 2 centimeter, 1 centimeter, 3 centimeter. We can actually target those small areas very precisely and ensure that while killing those tumors, we don't hamper the general functioning of the patient.
Okay, so Dr. Sandeep, as Dr. Satyajit was saying, there are some benign tumors that can come in the brain, like a neuroma, schwannoma, meningioma. So can an MRI differentiate between a benign tumor and a malignant tumor?
Yes, there are certain techniques, namely the diffusion and perfusion studies, and something called as a spectroscopy. So spectroscopy is we assess the internal contents, namely the metabolites So whenever there is a high-grade tumor, namely what Dr. Arun said, a glioblastoma multiforme has a significant elevation of choline. So if the patient, if there is choline or choline creatinine ratio, if it is very high, it is generally a high-grade tumor. Apart from that, certain basic characteristics like the higher grade tumors has more of necrosis within. Higher grade tumors generally have more of blood degradation product within. So whereas the pituitary adenomas or this all these kind of tumors, there will be not much elevation of choline, and these necrosis and hemorrhage are very less likely in these kind of tumors. Where but there is always an exception to the rule, like namely the kids tumor as a pilocytic astrocytoma. The metabolic function, it appears, though it appears like it is a high grade, but actually it is a low grade tumor. Namely, the pilocytic astroma is only an exception where the metabolic function is like a high grade, but it is actually a grade 1 or 2 tumor. So this is how we grade the tumors based on perfusion, diffusion weighted studies.
Okay, so Dr. Arun, how will your surgery differ between a benign tumor and a malignant tumor?
Yes, sir. So, malignant tumors, we will try to decompress as much as possible. However, we will not go for a complete excision. In benign tumors, we usually go for the maximal excision of the tumor because we know it is benign and it's unlikely to cause too many issues at a later date. So, we'll try for maximal excision. And also, we get a better plane of cleavage in benign tumors, which are usually, say, extraaxial outside the brain margins itself.
Okay. So, Dr. Vijay, you were talking about chemotherapy for children. So, how is it different from chemotherapy in brain tumors for adults?
Yeah, some of the brain tumors in children like medulloblastoma or piloblastoma, they are all more aggressive, or some germ cell tumors, they are more aggressive than the usual brain parenchymal tumors. So they are treated with the usual conventional chemotherapy agents like cisplatin, etoposide, are used for other fast growing tumors in the body, and they are as effective in these pediatric brain tumors. And also it is important to emphasize that in pediatric group, the brain is a growing structure, so the point is to avoid radiation at least until the age of 3 years wherever possible. So chemotherapy helps to at least push the age of being radiated at least to beyond 3 years. But of course, it is not absolute in all cases. But in most of the cases where we can do it, we try to give chemotherapy first so that we push the time when the child receives radiation to as far as possible.
So, Dr. Satyajit and Dr. Vijay, what are the challenges in treating brain tumors in children? Because the brain needs to grow normally, and when you treat, will it affect the growth of the brain? What about its learning capabilities? Will it be like a normal child? Is a common question that parents ask before treatment. Can you throw some light on that?
Yeah. So, pediatric tumors is a very challenging case for us radiation oncologists, at least because first thing is that, as I mentioned before, we have to ensure that the patient is immobilized. Immobilized in the sense that patient does not move. As Dr. Vijay mentioned, medulloblastoma are a very common childhood tumors. There we have to treat the whole of the craniospinal axis. By that we mean we have to treat the whole spinal cord. So along the back, the spinal cord runs in the midline up to the brain, from the brain until the pelvic area. So you have to treat the whole area up to a strip of around 5 centimeters from the brain until the pelvis. So it is a very large field. And again, giving chemotherapy with that makes it a little bit more toxic. But nonetheless, patients do tolerate because of the advancement both in chemotherapy and radiotherapy. And as far as neurocognition is concerned, as you mentioned, that parents are generally concerned. Yes, radiotherapy does affect the neurocognition of the patient, but then again, it depends on how much dose is delivered to which area.
Vijay, any long-term side effects of chemotherapy in children?
So one important side effect of chemotherapy in children is ototoxicity. That is, some of the drugs can cause impaired hearing in children. As we know, children learn to speak after they listen. So it is very important that the hearing capacity of the children should be maintained. So it is recommended that often during chemotherapy, their hearing capacity, according to the age, there are several tests that are there for measuring the hearing capacity that be monitored in children, so that during the treatment we don't permanently impair their hearing capacity. And in turn, if we impair their hearing capacity, the speech capacity will be in turn impaired. And in turn, if the hearing and speech are impaired, their academic and intelligence will be impaired. And ultimately, even though we make them live longer, they will become they may become much inferior compared to their peers, and it may affect them greatly during the later point of time. Another thing that must be emphasized is also that some of the drugs can affect the heart and the lungs also. So what we are doing is as much as low and as less chemotherapy as possible. We always try to risk stratify the tumors, and as little as possible the dose of drugs that are delivered during moderate regimens. So if a tumor is known to be less aggressive, then definitely less amount of chemotherapy is advised and recommended. And during chemotherapy also, and even after the completion of chemotherapy, we monitor for the development of these side effects so that they can be identified early and we can rectify any speech and hearing problems. And also it is very important that the child be looked for all these side effects even after the treatment and during follow.
And also the important thing to note here is that it matters that what condition the child is when we start the radiotherapy and chemotherapy. Suppose the morbidity is very high, the patient's as such consciousness or neurocognitive parameters are not very good at the start, we cannot expect much improvement going ahead in the treatment, as Dr. Vijay mentioned. So the condition in which we start the treatment is very important.
Okay. So like children, at the other end of the age spectrum, we can get very old people also with brain tumors. Say somebody who is 85 or more than 80, who is frail, who has poor energy reserves. Maybe there are multiple other issues like cardiac issues, lung issues. So Dr. Arun, when such a elderly patient presents to you with a brain tumor, what would be your way of managing it?
In elderly patients, when they usually present, it is in an advanced stage. So, usually above 65 or 70 years, what we commonly see is a glioblastoma multiforme only. So, a grade 4 tumor with all the treatment that is available with surgery, chemotherapy, and radiation, the survival is at an average around 15 months to 2 years. So it is very important to explain to the patient as well as the attenders about this possibility that even with all the treatment that is available, this is what is going to happen. So once the patients are ready, we'll still go ahead with the biopsy, or at least if the attenders.
I think we lost your audio. Can you? Hello?
Audible?
Yeah. We missed the last part. Could you repeat that?
Yeah. So once the family is counseled and they're ready for it, the principles of the surgery remains the same. So we will go for a safe maximal resection, try to remove as much as possible, reduce the tumor load, and then subject them to chemotherapy and radiation.
So what about Dr. Satyajit and Dr. Vijay? Would you still treat these patients the same way as you would treat an adult, or would there be any change in your management policies?
So Dr. Karthik, adults are, as you mentioned, as at one end of the spectrum, they're equally fragile as our children. So delivering them the dose we deliver to the normal adults or a healthy adult, say for a glioblastoma multiforme, which is a grade 4 brain tumor with very poor prognosis in the short term even, with median survival of around 14 to 15 months. We will not deliver the exact dose of 6 weeks. We may prefer something like 40 gray 15 fractions, which is a 3-week treatment or a staggered treatment of 2 to 4 weeks. We generally will first assess the general condition of the patient. Very rarely a patient above 80 will go to a 6-week treatment. We'll generally restrict the treatment to 3 to 4 weeks or preferably 3 weeks or maybe lesser than that depending upon the general condition. Dr. Vijay?
So, as far as chemotherapy is concerned, we must realize that with age, the organ functions decline. That is, the ability of the liver to metabolize the chemo medicines, and also the body, the hematopoietic, that is the blood forming system to regenerate the WBCs and platelets after chemotherapy is also limited. So, correspondingly, depending on the fitness of the patient, the age, the nutritional status, it is very important that we must make adjustments in the dose in the elderly. And in general, we try to keep it as similar to the adults as possible. But of course, it is a personalized individual to individual decision which must be taken into account, keeping in all the factors that are related to the patients in mind. And one brain tumor where it matters is the primary CNS lymphoma, where the cognitive deficits associated with its treatment are significantly high. And also it matters how much of the surgery has been done in a given patient, because if the surgeon has been able to resect the tumor in its entirety in a malignancy, I think we should reasonably be a little aggressive in the treatment, because potentially that patient may actually live longer with less morbidity.
So as the last part, Dr. Satyajit, there are different machines that can deliver radiation. So we hear words like gamma knife, cyber knife, linear accelerator, etc. Can you briefly tell us the difference between the various machines?
Yeah. So the machines which we use in the most of the centers are linear accelerators. So by linear accelerator, we mean a machine which generates radiotherapy by electricity. So there is no radioactive source per se implanted in the machine. So with modern techniques with electricity, we generate radiation from that machine. We call it linear accelerator, and the short form is LINAC. Higher versions of the machine have come. One of them is called tomotherapy. Tomotherapy is a machine which we can say it looks like an MRI or a PET machine. And here we can treat larger volumes of the disease. So as I was mentioning, a medulloblastoma, where we need to irradiate the whole brain and the spinal cord. So for larger treat fields like that, a tomotherapy machine helps, and the patient can translate in the bed, we call it couch, in the couch along the machine. So we can deliver larger fields with minimal side effects, with better effects. Then comes very advanced machines like cyber knife and gamma knife. I was lucky enough to work in my previous institute with cyber knife and tomotherapy. So what cyber knife does is, as I was saying, with a pituitary tumor or say a schwannoma, we want to patient is affording and wants to finish the treatment in one week or say one day. He does not want to sit around for 30 days and come daily. So we can deliver that dose, which is equally lethal to the tumor and which spares the normal tissue. So it ensures that there is minimal side effects for the patient with equivalent effect and sometimes higher effect also. The cyber knife and gamma knife are the machines which deliver with very high accuracy compared to the Linacs. And
that is
they deliver
basically
it
for
with,
stereotactic treatment.
yeah, stereotactic treatment. We call it a sutureless surgery. Yeah, so we can deliver those treatments. Our Linacs have also developed to have this capacity. Like the Linacs we have at a Bangalore center, Bhubaneswar center, we can deliver stereotactic treatment in 1 to 3 fractions. Also with the immobilization and the advancements we have, and the effects are as good as 6 weeks treatment. But we have to bear it in mind that not all tumors can be treated in a 1 day or 1 week treatment or 3 days treatment. We have some exceptions as to which tumor we can treat in a day or a week compared to in a, say, 6 weeks.
Okay, so if would the experts like to add anything else? If not, I would like to summarize all the points briefly. Dr. Arun?
To add as a final thought that the advancements in technology and the surgical techniques have been so much that brain tumor surgery is not as terrible or horrible as it seemed before. Diagnosed with a brain tumor, it is not the end of life. You still have to get up with it, and it can be treated. It may not be cured, but it can be treated, and it can significantly extend the life if done at a proper center with the proper techniques.
Dr. Satyajit?
Yeah, one point I like to add for the audience is that regarding the side effects, previously hair loss in the whole of the head, hair loss was happening. But with newer techniques and stereotactic techniques, we have limited hair loss to a very limited region. There are no other side effects. The skin gets darkened, but then when it is covered by hair, the side effects are not visible, and there is very minimal hair loss with stereotactic techniques whenever it is feasible and indicated for the patient. And we should always treat a patient even if the overall median survival is, say, for a grade 4 brain tumor is only 14 months. But I mean, once in a while we see a patient who can even live up to 5 years. We can see few patients who can live up to 3 years. So we should always continue treatment. Not taking treatment is never an option. We are always there we have techniques and methods to treat any kind of tumors.
Dr. Vijay?
Yeah, one thing I would like to touch upon, which we probably did not discuss all this time, is that we know that the reason why these tumors are so dreaded is that especially the high-grade brain tumors like glioblastoma is that they tend to recur. That is, even after we do surgery, chemotherapy, radiation, and also adjuvant chemotherapy, they tend to recur. But nowadays we have systemic therapies like bevacizumab and irinotecan, which can treat the recurrent tumors and keep them stable enough for another 1 or 2 years. And if we can keep these brain tumors which have recurred for another a couple of 1 or 1.5 years, these tumors, depending on their location, we are amenable for maybe even re-radiation or even re-excision depending on their location. So definitely now we are seeing many more patients who are, even though they have been treated and recurred, they have been re-radiated, and even after re-radiation, they are doing quite well. So nowadays, with the use of the systemic treatments that can stabilize the disease after recurrence, still there is hope that the patients can receive effective treatments that will help them survive for a longer time.
Thank the experts. I'll briefly summarize and give some take-home points. So brain tumor can affect any age, right from children up to the elderly population. The most common symptoms would be headache, vomiting, continuous vomiting, seizures as a common symptoms, and sometimes a part of the body may not function properly. MRI is the diagnostic modality of choice. Whenever you suspect a brain tumor, an MRI has to be done. In general, the first option of treatment of brain tumors is surgery. With modern techniques like neuronavigation, you can approach the brain tumor very accurately. And now, even without anesthesia, keeping the patient awake, critical areas in the brain, as Dr. Arun was saying, the speech area, they can be safely protected by doing surgery with the patient being awake. In case of benign tumors, sometimes just a single modality of treatment is sufficient, like surgery or radiation. But for malignant tumors, a combined modality of treatment is usually required. Surgery, which how much safely you can remove the tumor, you should remove it safely and follow it up with radiation and chemotherapy. Radiation, there are a lot of advancements have occurred. We do not treat the entire brain now for brain tumors. The radiation can be focused only to the affected area and the remaining brain can be spared. As Dr. Satyajit said, there are newer modalities called stereotactic radiotherapy where you focus the radiation very specifically to the tumor and you complete the treatment in 1 to 3 days. Chemotherapy also plays a very important role, and especially in improving the action of radiation to get better results. So in overall, if there is someone has been affected by a brain tumor, they need not totally be worried. There are very good treatment options available. Please speak to your doctor, learn about the newer treatment options that are available, and please undergo treatment, because with the modern treatments, your results are very good, side effects are low, and we are always trying to improve the life and quality of the patient. Thank you very much for this live telecast.
Thank you, everyone. Thank you.